تمام يا دكتور محمد، احنا سامعين حضرتك وشايفين البرزنتيشن.
Sorry بالتعطيل هو. Today we will be discussing the cardiac CT. There are some problems with the internet. I hope it goes well. So the story of cardiac CT actually started back in 1967. A British engineer, Godfrey Hounsfield, noticed that if you image the human body from different angles, then and you get multiple shots from these different angles, then you can get considerable variable attenuation of the X-ray beams that's penetrating the human torso. And this will allow minute differentiation between various organs and various tissues. But it has to wait for almost 14 years until 81 when ECG gating came into play. And this was the birth, at that time was the birth of the cardiac CT. Now, over the years, we developed the three types of cardiac CT. On the left side of the screen, you'll have the most preliminary form, which is the coronary calcium scoring. Coronary calcium scoring actually doesn't need an intravenous infusion, doesn't require dye. It's a quick procedure, it's inexpensive, and it requires low radiation dose, just maybe 1 millisievert. This is less than 1/10 of nuclear scanning and is reproducible. So wherever you do it, you obtain the same results. And it provides a lot of prognostic data. The idea is that you trace the areas of calcification in different coronary tree, right from the trachea bifurcation down to the base of the heart on the diaphragm, and then multiply this area by a density factor. So the calcium threshold is 130 Hounsfield unit. From 0 to 130, you multiply by 0. From 130 to 100 to 200, you multiply by 1, and so forth. So this we will talk about because this is the one of the most helpful types of cardiac CT. Then came coronary CTA or coronary CT angiography, which can be identify not only the calcified plaques but also the non-calcified plaques. It can also declare and evaluate the obstructive coronary artery lesions, and it can give an idea about the vulnerable plaque or the stable plaque, but it requires intravenous contrast, and we will detail on that. And then came the multi-phase CT, cardiac CT. The multi-phase cardiac CT is actually taking pictures and different intervals in the RR interval. And then by combining this into an imaging matrix, you can obtain a cine loop that tells you about the function of the valves, the presence of calcification in the valves, the presence of thrombi or vegetations, and as well, it gives you an idea about cardiac function. So these are the three principal forms of cardiac CT which are available now. Now in 2013 and updated in 2018 came the statin guidelines or the cholesterol guidelines. And everyone knows now, at least from the lecture on preventive cardiology, the first lecture of the two lectures on preventive cardiology, that statins are of considerable benefits in four subsets: clinical atherosclerotic cardiovascular disease, or familial hypercholesterolemia with LDL cholesterol more than 190 milligrams per deciliter, or patients with diabetes between the age of 40 and 75 years. These are secondary prevention. Now, the primary prevention is a fourth item, which is an estimated 10-year atherosclerotic cardiovascular risk more than 7.5 and maybe occasionally more than 5% by the pooled cohort equation. If you want to use the Framingham, that's okay. And we translated that based on other guidelines. If you have a risk between 5 and 7.5, you can replace it by one risk factor. If it is between 7.5 and 20, you can replace it by two risk factors. And above 20, you can replace it by three risk factors. Whatever method you adopt, particularly because the pooled cohort equation is used only in the States. But if you have doubt in the indication of statin therapy based on this classification, then you go to risk enhancers. And here in the lower panel, there are some of the risk enhancers. This includes calcium scoring more than 100. This has been updated, not 300, it's 100 or more, or equal or above 75 percentile for age, sex, and ethnicity. If you have a young individual with any form of calcium scoring, he's going to go up to 90 percentile. So it's very easy to get to the 75 percentile, particularly in young age. Or if LDL is above 160, or there is any form of genetic hyperlipidemia, or there is a family history, and if there is a high sensitivity CRP above 2 milligrams per deciliter. Other factors we mentioned it before, including chronic kidney disease, elevated lipoprotein beta A, elevated triglycerides above 170, or premature menopause, and inflammatory conditions like rheumatoid arthritis and HIV. So these are enhancers. So if you are in doubt of whether statin is indicated or not indicated in a particular patient, you go to the enhancers. If after going to the enhancers, you are still in doubt or the patient is refusing and you are engaged in a good conversation with the patient trying to convince him, then the third step is to go to the calcium scoring. So assessing the calcium scoring is of paramount importance in indicating which patient is candidate for a statin. For example, if calcium scoring is 0, then statin is probably not indicated unless the patient has a strong family history or is diabetic. If it is between 0 and 99, just less than 100, then statin is indicated if the patient is above the age of 55. And if it is 100 or above, then definitely statin is indicated. So this is the actual place of use of calcium scoring as a tertiary resort to factor that indicates and supplement your discussion with the patient, because as you remember, we indicated before that you don't tell the patient to take a statin, you engage into a discussion with the pros and cons of using a statin. So to further discuss the indications of calcium scoring, let's answer this question. Which of the following patients is most likely to benefit from calcium scoring? A 28-year-old asymptomatic patients with familial hypercholesterolemia, and FH is not family history, it's familial hypercholesterolemia, and LDL cholesterol is of 320 on atorvastatin 40 milligrams daily. B, a 48-year-old asymptomatic male with atherosclerotic cardiovascular risk score of 3.8, asymptomatic, no other risk factors. And C is a 61-year-old asymptomatic female with atherosclerotic cardiovascular disease risk factor of 7.8 who prefers to avoid statin. The correct answer here is actually C. The reason we are choosing that, this patient is a definitely high-risk individual. So you don't need to reclassify the risk. He's having familial hypercholesterolemia, and he's having LDL above 190. So he should be on statin, no doubt about it, irrespective of the calcium score. The second one is, on the other hand, is a low-risk individual. He's having a risk estimate of 3.8. That's below even 5% of the pooled cohort equation. Now, the third one is an intermediate person, not high risk, not low risk, and this is the kind of individual in which calcium scoring or calcium scanning is indicated. And this has been supplemented by the findings of the MESA study. The MESA study found that patients who are having atherosclerotic risk factors between 5 and 20, almost half of them having a calcium score of 0. So if you look into the left side of the screen here, these are patients with 10-year risk of the pooled cohort equation less than 5. So whether the calcium scoring is 0 or non-zero, that's above 0, always the risk is less than 5%. So it's not indicated in statin for statin. So these patients who are having an atherosclerotic cardiovascular risk factor less than 5%, they are by definition not indicated for statin. On the other hand, if you go to the right side of the screen for patients who are having the 10-year risk score, atherosclerotic cardiovascular disease risk score more than 20, or what we translated it into 3 or more risk factors, then these patients, whether they are having a calcium scoring of 0 or non-zero, they are always above the threshold of 7.5, which we indicate, or the guideline indicate as a candidate for statin therapy. So in neither the low risk individuals or the very high risk individuals, the calcium score is indicated. Now, if we look into the intermediate panel here, these are the patients who are having a risk score between 5 and 7.5, and on the right side, you have between 7.5 and 20. Here, calcium scoring is going to make a difference. If the calcium scoring is above 0, then you pass this threshold of 7.5. If it is below 0, then you stop short of the risk of the level of threshold of 7.5. So calcium scoring is going to be indicated in this intermediate risk group. So the bottom line of this important study, the MESA study, is that calcium scoring is essentially indicated in patients who are having an atherosclerotic cardiovascular risk factor between 5 and 20. And if it is 0, then statin probably are not indicated. And if it is non-zero or above 0, then statin is indicated. So this is the primary indication of calcium. Based on that, the American Society of Calcium of CT scanning proposed the following indication of calcium scoring. It's appropriate to perform calcium scoring testing in the context of shared decision-making for asymptomatic individual without clinical atherosclerotic cardiovascular risk who are between the age of 40 and 75 years of age in the 5 to 20% 10-year risk group, and selectively in patients less than 5%. And these are the patients who are having a premature onset of atherosclerotic cardiovascular disease or a strong family history. So over time, the value of calcium scoring changed from just screening for coronary artery disease to using it as a tool for decision making to indicate which kind of prophylaxis, and particularly whether statin is going to be given to these patients. So to summarize the important points about calcium scoring, the value of calcium scoring is to reclassify risk both up if it is above 0 or down if it is 0. If you have a calcium scoring of 0, you are very low risk, and the risk is just or about 0.1% per year. Remember from the last lecture, if you have a normal nuclear scan, the risk is 1% per year. Here we are talking about 0.1% per year. And the warranty period in a normal nuclear scan was 5 years, but look at the warranty year here. Warranty period, if you have a calcium scoring of 0, it's between 10 and 15 years. Obviously, there is about 20% change per year for calcium scoring, but you don't need to repeat it frequently because that's not going to tell you much more information than the initial evaluation. It's not appropriate for patients with non-coronary artery disease or symptomatic patients. So we rarely do it for symptomatic patients. The only exception are symptomatic patients that are having a very low risk as evaluated by any of the different scoring that we have been talking about. If you have a calcium scoring that's above 0 or high level of 0, then you need some form of intervention. Patients are having a high calcium score, they are prone to congestive heart failure, myocardial infarction, stroke, and even atrial fibrillation. So you need some form of intervention. And if you have a calcium scoring is 0, then you don't need an additional test for the evaluation of these patients. Now we move to CTA or coronary angiography. For those not well familiar with how the procedure is being done, usually we pre-medicate the patient with nitroglycerin to dilate the epicardial coronary arteries, and we try to come down with the heart rate to the 60s. If you have a dual source CT scanning, then you can go up above 60 to 70 or even 80. The patient preparation, you need a wide port intravenous line. Renal insufficiency or contrast allergy is a contraindication to the procedure. And the scan time is very short, just a few seconds, less than 10 seconds. The image reconstruction requires a few minutes, and the interpretation requires somewhere between 5 minutes to 45 minutes, depending on the complexity of the interpretation and the complexity of the coronary arteriogram. Now, the coronary arteriogram by CT is usually divided into 4 categories. You have a minimal lesion between 0 and 25%, mild between 25 and just less than 50%, moderate between 50 and less than 70, and severe more than 70%. So these are the different classifications by which we estimate the severity of the lesion. And in addition, the CT provides something which the invasive coronary arteriogram doesn't provide, and that's the high risk characteristics of the plaque. So we will come into that in details about low attenuation plaque with positive remodeling. That's a plaque in which there is increase in the outer diameter of the vessel, a Glasgow effect, spotty calcification, and what we call the napkin ring sign, and I will come to that. So it provides you not only with an idea about the degree of luminal stenosis, but it as well provides you with the plaque characteristics, whether high or low. So this is from the appropriate use criteria. The most appropriate use criteria for coronary CTA is the low intermediate risk probability of coronary artery disease. Obviously, for acute coronary syndrome, you go to the cardiac catheterization, and it's inappropriate to use the coronary CTA. For high probability CTA in stable conditions, it's uncertain whether you use it or not. You don't use it. So it's essentially for the low and intermediate probability of coronary artery disease. So let's go to the next question. When compared with the use of other testing strategies, like, for example, coronary MPI, the use of CTA for the evaluation of acute chest pain is associated with all of the following except reduce the length of stay, reduce the time to diagnosis, reduced rate of invasive angiography, or reduced emergency department cost. So except. So the correct answer here is C. Actually, you get reduced length of stay in the emergency department and in the hospital in general. You get a reduction in the time of diagnosis. That's why the nice recommendation in UK is advising the use of CTA for stable and unstable chronic conditions, whatever their presentation at the time of presentation. And there is reduction in the emergency department cost, but actually because of increase in the use of invasive angiography, the total hospital expenses is neutral. There is no change. So you decrease the emergency department cost and stay in the emergency department, but as a result of using CT, there's 2% increase in the use of invasive coronary arteriography, which increases the expense. So in patients with acute chest pain, CTA is valuable in finding in decreasing the time to hospital discharge. And as well, you need only one set of negative troponin level or cardiac biomarkers to do the procedure. Remember, in patients with nuclear scan, you need 2 sets of negative biomarkers. You have to wait for some time, but here you can go right. Of course, now with the repeated, with the high sensitivity troponin, this recommendation might change. You might find the other explanation for the patient's symptoms, like here, for example, you have a dissection, which is involving the root of the left main coronary artery. You can diagnose pulmonary embolism, or you can diagnose the penetrating aortic ulcer in the descending aorta. You can diagnose pericarditis, and you can diagnose even hiatus hernia. And in this lower right image, you will find that there is gastric tissue located in the chest. So this explains reflux esophagitis or hiatus hernia on an association of both of them. So in acute conditions, you can find that it's variable not only to detect coronary artery disease, but other conditions as well. And in the AHA-ACC 2014 guidelines, coronary arteriography is associated with rapid assessment, high negative predictive value, decreased length of stay, and reduced costs. So this shows that in one study, which is actually it's a meta-analysis of 4 trials, there was definite increase in the incidence of invasive angiography by about 2%, and in person, and the increase in the incidence of revascularization again by 2%. So the procedure has the downside of indicating by the oculostenotic index, if you have something that's more than 70%, you rush to the cath lab, and this increases, of course, the implementation of invasive angiography and intervention. Which of the following indications for cardiac CT is most appropriate? A 38-year-old man with atypical chest pain and had an invasive angiogram which demonstrated anomalous retro-aortic left circumflex with minimal plaques. B, a 56-year-old female with mechanical mitral valve replacement who had an inconclusive echocardiogram for suspected bacterial endocarditis. A 45-year-old man with typical chest pain who has 3 prior stents located in the distal RCA and PDA, or D, a 34-year-old female with hypertension, hypercholesterolemia being evaluated for palpitation. So which of these 4 choices is a good indication or appropriate indication for cardiac CT? The correct answer here is B, but let's go through them one by one. If you look into the first patient, this is a patient, 38-year-old male with a very benign congenital coronary anomaly. If you have a left circumflex arising from the right coronary cusp, then this is 100% of the time is moving behind the aorta. So there is no point that it gets compressed between the aorta and the pulmonary artery, or between the aorta and the right ventricular outflow tract. So a circumflex arising from the right coronary artery or arising from the right sinus of Valsalva is always benign. You don't need to do CT to confirm its pathway. If you go to the number 3, this is a patient with the typical chest pain with 3 prior stents located in a distal location in the coronary arteries. The CT is a poor choice in demonstrating in-stent stenosis or any problem with a stent in the distal vessels. It's appropriate whenever you have a stent equal or more than 3 millimeters and located in the left main, or at most in the proximal LAD. So C is wrong as well. And then if you look to D, this is a benign condition, low risk individual, and so you don't need a CT for it. So the appropriate answer is B, which is now this shows you the use of the CT according to the appropriate use criteria. This is a patient with bicuspid aortic valve, and you have a filling defect here, and this is actually a thrombus. This patient has been neglecting routine anticoagulation, so he got a stuck valve, the thrombus was not seen by echocardiogram, but was seen by the CT. Now, this is another patient who is having clinical manifestations of bacterial endocarditis. Of course, the hospital, the story of the patient, history taking is paramount in these conditions, and you'll find here a filling defect, which indicates the presence of a vegetation, which was not seen by transesophageal echocardiogram. So you can use it in certain situations, which is non-coronary. This will show you the pathway of the circumflex, which is arising from the right sinus of Valsalva and is going behind the aorta. It is not passing between the aorta and the pulmonary artery, so there is no point of compressing this artery. And the only problem is probably when you planning to do some intervention, you need some time to engage this vessel. If you go to the lower panel here, this is another anomaly, which is again very benign. The coronary artery, aberrant coronary artery, the LAD arising from the right sinus of Valsalva or the proximal right coronary artery, and is prepulmonar. So it's actually not compressed between the aorta and the pulmonary artery. Again, a benign anomaly, although much rarer than this. This is a very common anomaly, and at the same time is always a benign anomaly. This stands in contradistinction to the situation in which the right coronary artery is arising from the left sinus of Valsalva. If you look into this panel here, you will find it's located between the anterior pulmonary artery and the posterior aorta, so it might get compressed between them. But actually, it's not that serious like the left coronary artery arising from the right sinus of Valsalva. When the right coronary artery arises from the left sinus of Valsalva and is being located between the pulmonary artery and the aorta, usually we don't do anything if the patient is asymptomatic, particularly in old age. In a young individual with symptoms of ischemia, you need to do a de-roofing. We explained that before, because part of it is usually in the wall of the aorta. So just if you remove the tissue between the coronary artery and the aorta, a de-roofing operation, that's enough to allow unobstructed blood flow. But if it's discovered accidentally in an elderly individual, particularly if asymptomatic, then there is controversy about the ideal line of treatment, but you are allowed to just forget about it. This is in distinction to the condition which is very serious, in which the left main coronary artery arises from the right sinus of Valsalva and passes between the pulmonary artery or the right ventricular outflow tract, like in these two pictures. And as we explained before, the origin of the left coronary here might be just a slit. It might pass into the wall of the aorta, and it might dip into the musculature of the right ventricular and left ventricular myocardium down into the interventricular septum. Under these circumstances, it may be compressed by contraction of the interventricular septum or the adjacent myocardium. Now, as you see, one of the things during coronary arteriography, invasive coronary arteriography, that directs your attention to the presence of this anomaly, if you find the left main is so long. Usually the left main is somewhere between 0 and 5 centimeters, but if you find it extending to 8 or 10 centimeters, think about an abnormal course. And we used to, in the past, to do a complex form of coronary angio to find this out. Now, the gold standard now to find this diagnosis unambiguously is the CT. So under these circumstances, you will get the picture of the coronary artery located between the outflow tract of the right ventricle here. And you don't need to differentiate between whether it's going intramurally or extramurally. Both of them, they need some form of complex surgery to get this coronary artery outside it and implant it in the appropriate sinus of Valsalva. So the gold standard is actually for this kind of anomaly is CT angiography. Next question, which of the following is true regarding the use of coronary CTA to evaluate a patient with a stable chest pain? So we are now moving from acute chest pain to stable chest pain. The use of CTA leads to similar outcome as nuclear myocardial perfusion imaging. B, the use of CTA leads to higher rates of coronary revascularization when compared with either exercise treatment test or nuclear myocardial perfusion imaging. The use of CTA leads to higher utilization of statin or all of the above. The correct answer is all of the above. So all of this is actually correct. The use of CTA leads to similar outcome as nuclear MPA. This was the conclusion of a study called the PROMISE study. I will show it to you. Although recently a British study came out that indicated that CTA supersedes nuclear scanning in this, particularly if you combine an anatomical diagnosis like that provided by CTA with a functional diagnosis that provided by exercise test. So the Scott Hart trial, which I will show you the results now, just contradicts with the PROMISE trial. So in the Scott Hart trial, CTA superseded nuclear MPA, and the CTA with exercise test superseded CTA alone. The use of CTA leads to a higher rate of coronary revascularization. I just alluded to there is 2% at least increase in the occurrence of performance of coronary revascularization and the invasive coronary arteriography. And of course, it leads to a higher utilization of statin. So all of the above is the correct answer. Now, this is the PROMISE trial, and as you see, the primary endpoint was death, non-fatal myocardial infarction, hospitalization for unstable angina or major procedural complications. And as you see, there is a trend, not significant, but at least the p-value is 0.75, so you can say that there is no difference between a functional test, which was nuclear scanning in this trial, and an anatomical test, which is CT. But the difference came here that in patients who are having CT angiography, they are less able, CT angiography, they are less able to identify ischemia than patients who are having the nuclear scan. The reason for that is that CT, you will diagnose ischemia if there is an obstruction above 50%, particularly above 70%. But now we know that there is something called the INOCA. INOCA is ischemia with no obstructive coronary artery disease. So sometimes the presence of just the plaques, particularly if the plaques are numerous. So the presence of 4 or more plaques, non-obstructive, can produce ischemic manifestations exactly equal to the presence of a plaque. So we no longer disregard the plethora of non-obstructive plaques. So under these circumstances, as you see, there is a statistically significant difference between functional tests, which can discover the ischemic outcome of non-obstructive plaques, and the failure of CT scanning to find the functional significance of CT of non-obstructive plaquing. So as a result of that, there is the Scott Hart trial, a British study was carried out to find out whether functional tests are better than anatomical tests or not. Actually, in about 4,000 patients, divided almost equally between standard care, which was in this trial just an exercise treadmill test, or standard care plus CTA. And as you see, the outcome, various cardiovascular events, including myocardial infarction, hospitalization, congestive heart failure, and arrhythmia, was less with the, if you do, you can discover them more clearly if you do a functional test in association with anatomical tests. In this trial, the functional test was the standard exercise treadmill test, and the anatomical test was CT. So as you see, there's some controversy which one of them is better, but actually you have the advantages and the disadvantages for anatomical versus functional tests, and I will come to this very soon. Now, this will show you that if you compare a functional test with an anatomical test, then the anatomical test will reveal a higher odds of undergoing invasive angiography, and a higher odds of revascularization, as I just alluded to, by almost 2% for each of them. Absolute difference. The next question is 61-year-old male with hypertension and coronary CTE to evaluate symptoms of stable chest pain. His ECG is normal. He is treated with aspirin and atorvastatin 18 mg daily. CTE shows a moderate stenosis. We look into this panel. The CT angiogram, there is a moderate stenosis. So what's the best next test? Is it invasive angiography with FFR? Is it invasive angiography with stenting, exercise SPECT MPI, or check troponin? The correct answer here is C. You can argue that the correct answer here is E. So the net outcome of this question is that if you have an intermediate lesion, lesion of intermediate severity here, like 50% or 60%, you need a functional test. Of course, FFR is a functional test, but it's an invasive test. SPECT MPI is a functional test, is non-invasive, so it takes some priority for that. Now we are having on the horizon a CT FFR, and the CT FFR, you need good pictures, and at the same time we know that the FFR indicated by CT is valuable at extremes of stenosis. So if it's very low, if it's very high, then it's acceptable, having acceptable sensitivity and specificity. But between 0.6 or 0.7 or 0.8, it's of no value. And at the present time, it's not available everywhere. It's only available in a company in California. Even in the States, they send it to this company and they receive the result after a few days. So if you have an intermediate severity, you have to go to a functional test. And this is very clearly demonstrated in this slide. If you have an stenosis by CT somewhere between 0 and 50%, then all what you need is prophylactic therapy. You don't need invasive or non-invasive functional tests. If you have a moderate stenosis between 50 and 70%, then under these circumstances, you should consider a functional test, whether nuclear MPI or exercise treatment test, as we alluded to before. If you go above 70%, then you either consider a functional test or you go directly to invasive coronary arteriography. If you are having a picture from CT of left main or three vessel disease, then the recommendation is to go to an invasive coronary arteriography. So that's how we can use the CT in the context of the different investigative modalities which we have. So long as the CT angiography shows a mild or minimal stenosis below 50%, prophylactic therapy, medical therapy alone. If you go between 50 and 70%, consider a functional test. If you go above 70%, a functional or invasive angiography. If you have left main or three vessel disease, then an invasive angiography. Now, this is another question. A 57-year-old female with hypertension and atypical chest pain. How should this patient be managed? A, SPECT MPI, B, invasive angiography, 3, medical management, 4, medical cardiac MRI. Now, if you look into this, this is the right coronary artery, the circumflex, and the LAD. There is just non-obstructive plaques. So obviously, if you have non-obstructive plaques, the indication will be medical management. None of the other choices is correct. But remember that non-obstructive plaques, if they are numerous, they cannot be disregarded as a benign lesions. We know that this kind of disorder, if it is numerous, then it's equivalent to obstructive plaques. Ischemia should be treated, but treated medically, obviously, no intervention, and therefore no further imaging is required because intervention is not going to help anything. So this compares an anatomical diagnosis with functional diagnosis. So CTA has a value in ruling out disease because of its very high negative predictive value. It can detect subclinical plaques, as we saw in the previous pictures. It is limited by extensive calcification of the coronis, which interferes with the appropriate evaluation of the degree of stenosis. And obviously, it's limited also by the need for contrast agents and low heart rate. And the pictures are not that great in patients who are morbidly obese with BMI above 40. On the other hand, a functional test like myocardial perfusion imaging is able to determine the hemodynamic significance of significant lesions, is able to identify the presence of ischemia. Remember, we are driven always by ischemia, although it doesn't have a good correlation with the outcome. But it might underestimate the extent of disease because you will not see the subobstructive plaques. And we now know that the subobstructive plaques, particularly if they are numerous, they are not a benign encounter. Now, this shows again the various degrees of stenosis: minimal stenosis, mild stenosis, moderate stenosis, and severe stenosis. But remember that the CT is not always a test for stenosis, but always gives you a good idea about the nature of the plaque. So if there is a positive remodeling, that's widening of the outer diameter of the vessel, that's the Glebov effect. It tells you that you are dealing with a nasty plaque that's liable to rupture. Again, if you have a low attenuation plaque, this means that there is an increased fatty content and inflammatory content. If you get a spotty calcification rather than dense and extensive calcification, and if you get the napkin sign, sorry, I don't have a picture for the napkin ring sign. Napkin ring sign, you have a high attenuation, that's a white ring surrounding a plaque. So these four features indicate a high-risk plaque. And a high-risk plaque can rupture, of course, but at the same time, it can progress. So it has an adverse acute prognosis in terms of rupture and producing acute coronary syndrome. At the same time, it progresses rapidly and can result in ischemia. So that's one big advantage of CT that cannot be mimicked by any other non-invasive procedure. So in conclusion, for the coronary arteriograms, there are many different types of cardiac CT. Cardiac CT is selected in the asymptomatic patients to show the calcium scoring. CT angiography is useful for the acute coronary syndrome as well as for stable patients, as we just alluded to, and is also useful in other conditions. So if you look to the other conditions, sometimes in patients with sinus venosus defect, in which there is a defect at the upper part of the interatrial septum, you can't see it even by occasionally, you can't see it by even transesophageal echo. So CT is an excellent method of demonstrating it. And in this view, you see an anomalous left coronary artery going to the right coronary artery going to the right atrium. So it shows the sinus venosus here in the upper part of the septum. Can show also overriding of the superior vena cava over the septum. At the same time, a sinus ostium secundum atrial septal defect is shown here in this view as well as in this view, and a ventricular septal defect can be seen. Obviously, it's not the first choice for the declaration of these conditions, but it can be a final arbiter in doubtful cases or difficult cases that cannot be diagnosed straightforward by echo. It's also very valuable in depicting the mitral as well as the aortic valve morphology. Can show you the presence of the diameter of the aortic ring, the presence of calcification, the intensity of calcification, and we know that the intensity of calcification goes hand in hand with the severity of aortic stenosis. So in males, if you get more than 2,000 Hounsfield units for the aortic valve, it signifies significant aortic stenosis. In females, 100 and 1,200 is an indication of severe stenosis. The value of TAVR is unmatched, of course. As you see here, this is the area under the curve comparing the severity of stenosis identified by an echocardiogram as well against the severity of stenosis identified by the degree of calcification. The two curves are almost superimposable. In patients with TAVR, you can identify the morphology and the diameter of the aortic ring, the condition of the outflow tract of the ventricle. It can predict the complications, including the coronary ostial occlusions, particularly if you have a low origin of the right and left coronary arteries. So it can measure for you the degree of elevation or separation of the aortic of the coronary arteries from the aortic ring. It can also give you a good idea about the right left ventricular outflow tract, which predicate the occurrence of heart block post-procedure. And even post-procedure, it's also valuable in telling you the degree of opposition of the struts of the stent. Here in another picture, you can see the displacement of calcification of the coronary arteries in this condition, of the calcium in these conditions, and the opposition of the stent's struts against the wall of the aorta. So as you see here, it's very valuable in detecting coronary calcium in asymptomatic patients and detecting the extent of coronary stenosis in acute and chronic condition and the value in extracardiac condition. So I stop at this stage and get your questions if you like. I hope Ahmed Shahata is with us because he will be able to answer many of the technical questions. He has been working in that field for a long time, became an important expert in this field. محمد.
دكتور محمد أنا مع حضرتك.
أسئلة؟
هو دكتور أحمد شحاتة معانا، وفي أول سؤال جه بيسأل عن الuse of multi-slice CT coronary angio for assessment of coronaries before valve surgery.
اليوز اوف ايه؟ قول لي تاني السؤال.
Multi-slice CT coronary angio for assessment of coronaries before valve surgery.
We don't use it for before valve surgery as a routine unless there is a contraindication for invasive angiography, because we use it only in patients with low or intermediate risk of coronary artery disease. So in valve surgery, patients with the indication for coronary arteriography are elderly individuals above the age of 40 or 45, and at the same time, if you have a calcific aortic valve or a calcific mitral valve, then this usually indicates probable coronary artery disease. Many of these patients are having chest pain, so most of them, they don't fall into the category of low and intermediate risk because of their age and because of their the calcification of the valve. So usually you need an invasive arteriography. So we don't use it as a routine in patients. You cannot use it at the same time as a replacement because you are giving almost 100 cc of dye. So if you don't get solid information, then you are going to repeat the procedure by invasive angiography. So that's the double dose of dye. A third factor is that many of these patients with aortic valve disease in particular, they are having chest pain. And if they have chest pain, there's a 50% possibility of having coronary artery disease, which needs intervention, and 50% that they do not have coronary artery disease, but still they are high risk. So because of these three factors, we prefer using a coronary arteriography, invasive coronary arteriography, rather than coronary CT in preparing patients for surgery.
في سؤال اللي بعد كده بيسأل عن ال accuracy of CT angio in patient with atrial fibrillation.
The problem with atrial fibrillation is that gating is difficult. So under these circumstances, we usually try to get the patient to a slow heart rate, so the degree of the irregularity becomes much less marked. And I think with the new machines, you can get all the information from one cardiac cycle. So if you have a dual source 320 detector, then under this and the capability of getting everything in one cycle, then under these circumstances, you can do it in atrial fibrillation. But one of atrial fibrillation is not a contraindication, but it can produce a suboptimal picture unless you take care that sometimes you can pace the ventricle. If the atrial fibrillation is slow, let's like, for example, ventricular responses in the 60s, then you can pace the ventricle at a rate of 75 or 70. Under these circumstances, you have regular heart rate, so you can take a good picture. أحمد شحاتة ما يقول لنا هو بيعمل، هو مش موجود مع إن أنا قلت له يتواجد.
هو موجود يا دكتور.
طب خليه يجاوب السؤال ده.
اوكي حاضر. دكتور احمد.
ازي حضرتك يا دكتور محمد؟
يا أهلا حبيبي. تعملوا
زي
ايه
ما
في
حضرتك قلت يا
الأكتر
دكتور
fibrillation؟
محمد بالظبط، هو الهاير اند ماشينز زي ال 320 سلايسز ممكن ان هي توبريت in patient with atrial fibrillation. هي كان الهاير اند ماشينز can take the whole heart in one cycle. So upon one cardiac cycle we can image the whole heart. زي ما حضرتك قلت بالظبط، بس provided ان السايكل الواحده اللي هياخدها تكون short enough. In heart rate between 60 to 80. Another trick is the use of dual source higher end machine, like the 256 machines. Dual source, the temporal resolution is very high, and we can get good images in patients with atrial fibrillation. Of course, we may not see the distal segments of the vessels, but it can give the adequate idea about the proximal segment, left main, proximal LED circle, and right coronary artery.
Which are the important things.
Yes.
Okay. Now let me explain للناس اللي هم جداد خالص يعني ايه 320 ولا 6. These are the number of detectors, detector rows. So if you have a fan beam getting out of the X-ray source, and they are detected by a detector. الديتكتورز دول بيبقى عددهم مترصصين في روز. الرود ده هو يتراوح ما بين 16 وده افتكر ما بقتش موجود، ده كان في البدايه الى 320. كل رو من دول في حاجه تتراوح ما بين 800 الى 1000 ديتكتور. So you can imagine the number of detectors اللي موجودين عدد كبير. فكلمه 320 معناها عدد الروز اوف ديتكتورز اللي موجودين، او 256 الى اخره. So this is dual source معناها انك انت بدل ما عندك 1 سي ارم عندك اثنين. الاثنين دول هم فيهم كاميرا وديتكتورز separated from each other. So this allows the procedure to be done in a shorter time interval and allows better temporal resolution. The number of detectors لما بتزيد you get better spatial resolution. So next question.
اوكي السؤال اللي بعد كده بيسأل عن what is the meaning of low attenuation plaque؟
attenuation of the X-ray معناها انك تمنع البنتريشن. So if you have high attenuation هتبان ابيض. احنا كل الهاونس فيلد ده in relation to water. Water is zero. If you get a high attenuation you go to like bone and metal. البون الاتنيويشن بتاعه حوالي 1600 1800، الميتال حوالي 2300. If you get below zero اللي هي الووتر like fat and air ناقص 80 والاير ناقص عدد اكبر من كده او اكتر من كده بكتير. So كلمة high attenuation معناها انك انت you attenuate the X-ray they do not penetrate appear ابيض. low attenuation معناها ان السيجنال ضعيفه وما فيش attenuation جامد وبالتالي البيكتشر will appear gray. So that's the difference between high attenuation and low attenuation. This is a vocabulary which is being used by radiologists. I don't blame anyone if I...
اوكي السؤال اللي بعد كده بيسأل عن the role of CT in determining the degree of mitral regurg compared to transesophageal echo.
هو المالتي فيزيك سي تي السبيشال ريزوليوشن بتاعه is good لكن التمبرال ريزوليوشن is not that as good as the echocardiogram. So we prefer still echocardiogram in evaluating the severity of mitral regurg. But if you have some difficulty like presence of severe valve calcification or particularly presence of prosthetic valves, the prosthetic valves, the blooming effect of the prosthetic valve doesn't show you the severity of mitral regurgitation. And the presence of paravalvular leak, all of these can be helped by CT, but usually the gold standard in the evaluation of CT of valvular regurgitation is the echocardiogram. لكن برضه نسمع رأي أحمد شحاتة في الكلام ده.
هو
دكتور أحمد.
in the evaluation of the mitral procedure زي ما برضو دكتور محمد ورى في السلايد it can delineate the anatomy. If it can delineate masses in paravalvular leak, it can detect the defect and quantify the defect and help the interventionist. If you need to put a plug, it can identify where is this defect, if there is multiple defect and its exact or precise location. However, the CT in evaluating mitral regurgitation cannot detect regurgitant, just delineation of the anatomy, masses, defect, their precise location, and tailoring intervention.
طبعا CT PET بيستخدم في diagnosis of bacterial endocarditis. So this is a condition in which the association with another imaging modality can help the presence of inflammation, paravalvular abscess, or paravalvular masses. So echo is still the primary investigative method for the diagnosis of mitral regurgitation and aortic regurgitation, aortic stenosis, and so forth.
تمام.
Okay. سؤال بيسأل in a patient with 50 to 70% stenosis in multi-slice CT coronary angio and a negative functional test.
50 to 60?
50 to 70.
50 to 70, okay.
And the negative functional test, is it enough to manage this patient with medical treatment only?
طب ما دي احنا اتكلمنا فيها انك انت 50 to 70 you can either choose انك تعمل له functional test عشان تشوف السيجنيفيكانس بتاع this lesion or invasive angiography occasionally. The place of CT FFRR is still in its infancy. So you cannot say this patient to go to medical treatment. This patient needs further evaluation. يعني عدم عندنا 50% سواء 50 to 70 or 70 to 99. Under these circumstances, the CT will be one of the investigations, but not the final investigation. So you need to do, if I get like 60%, I want to know whether it's producing ischemia or not. ECG can be interpretable. A patient can exercise, so exercise ECG test. If not, then exercise nuclear. So this is an indication for further testing.
ولو الفانكشنال تيست نيجاتيف البيشنت ينفع نمانج ميديكال تريتمنت بس؟
functional test negative and it's very well readable, then you stop at this stage. طبعا ممكن يبقى العيان عنده another indication وهو resistant chest pain to medical treatment ده indication for intervention. لكن العيان اللي ما عندوش حاجه زي كده هو انه عنده 70% أو 50% أو 60%.
دكتور محمد هو الصوت بيقطع.
This should not be neglected. أقول تاني؟
هو الصوت كان بيقطع.
اللي أنا بقوله إن إذا كنت عدينا 50% يعني من 50 to 70 to 99, these patients should be investigated more. The traditional method is to go to non-invasive testing, functional testing between 50 and 70, and go to functional set testing or invasive angiography من 70 to 99, unless the patient is having this lesion in the left main or three-vessel disease, so you go directly to invasive angiography. So it should not ما تقدرش تقول العيان عنده 60% روح بقى.
تمام اوكي.
برضه نسمع رأي الدكتور أحمد.
زي ما دكتور محمد قال برضه نفس الكلام، هو البوردر لاين ليجن السي تي مش should not be relied upon as the sole investigation or the sole method of assessment. It should be in the context of the clinical scenario. Even if the function test is negative and the patient continue to have chest pain, I think we have to angio the patient.
Okay.
Sometimes every test have its sensitivity and the specificity and depend on the expertise that read the imaging test. Therefore, the clinical context of the patient is paramount importance. If he continue to have chest pain or ECG changes or enzymes positive or any other high-risk criteria with borderline CT, I think you have to angio the patient even if the functional test is negative.
Okay.
اوكي. السؤال اللي بعد كده بيسأل is there a certain figure of calcium score above which you cannot do multi-slice CT coronary angio?
Is there a threshold above which we do?
We cannot do coronary angio, multi-slice CT coronary angio.
لا هو ما اعتقدش ان فيه ثريشولد، لكن الثريشولد اللي موجود في يعني السؤال ممكن يتسال ب different methods. هل في calcium scoring above which you have to investigate the patient by coronary angio او انك انت تعمل له functional test? There is no threshold, but most of the people above 1000 calcium scoring probably they require that the patient is having a functional test. نيجي للجزء الثاني من السؤال وهو هل ال presence of extensive calcification تمنعني ان انا اعمل coronary angio؟ No، ما تمنعنيش، لكن ال reliability ان انا اشوف ال findings اللي هي will be diminished. So sometimes you get a report in which there is because of the intense calcification you cannot evaluate the severity of the lesion. But we know that calcification is a part of the plaque, and if you have dense calcification and the patient is having symptoms, then he probably has a significant stenosis, so he should be angioed. But under these circumstances, you have to decide ahead of time whether you are going to go to invasive angio, or because of the extensive calcification, you predict that the coronary CT is not going to be very helpful. But it's not a contraindication. أحمد شحاتة.
الكالسيفيكيشن الثريشولد زي ما دكتور محمد 1000 هو معظم السنترز بياخدوه كاز exclusion from invasive from contrast enhanced CT because of two things. أول حاجة إن ال possibility of having at least the possibility of having at least a single significantly stenotic lesion is above 90%. The other thing زي ما دكتور محمد قال technically we cannot see because of the extensive blooming of the calcifications. We cannot read the degree of stenosis. لكن بعد في شوية modification أحيانا في الكوروناري اكتيزيا، ودي ممكن يبان حتى في ال non-contrast enhanced study مع الكالسيوم score. If the vessel is much ectatic you may inject even with higher calcium score لأن ال diameter بيبقى very large، ومع الاكتيزيا معظم الكالسيفيكيشنز بتبقى في الوول، بس طبعا ده اكسبشن قوي. برضو لو عملت كالسيوم سكور ولقيت في very dense calcification في الديستال ليفت مين او proximal LED، حتى لو الكالسيوم سكور 400 بس هم amalgamated في critical area، انا بكنسل ذا تيست حتى لو اقل من الثريشولد ده، لان في النهايه هقول له ان في جزء critical جدا I couldn't interpret، فساعتها you are justified to cancel the test.
اوكي. السؤال بعد كده بيسأل is there a role for CT angio after a positive functional test?
A positive functional test depending على السكور الديوك سكور. إذا كان الديوك سكور indicating a high risk individual, it's an indication for invasive angiography. So I don't think that we have to do a coronary CT after a functional test to get what يعني what's the idea؟ عاوز تشوف إيه؟
السؤال بيسأل what are the factors
ممكن انك انت you have strong suspicions of coronary artery disease and the functional test is negative. but it depends على ان النيجاتيف ايه. يعني افرض واحد exercised for 9 minutes no STT wave changes and despite that you think ان هو coronary artery disease. Even if you prove ان هو coronary artery disease, the outcome will be brilliant. So under these circumstances I don't think that you need انك انت تاخد العيان ده تعمل له CT angiography.
Okay. سؤال بيسأل what are the factors responsible for temporal and spatial resolution؟
ده احمد شحاته ده يجاوب.
السباتيال ريزوليوشن زي ما دكتور محمد شرحه برضه لسه شرحه، كان بيتكلم ان هو بيعتمد على النمبر اوف ديتكتورز. الديتكتورز الويدث اوف ذا ديتكتورز تقريبا بيبقى 0.67 ملم. ده معناه ان لو في حاجه اكبر من 0.65 هيقراها از 2 بوينت، لو حاجه اقل من الديستانس دي هتتقري از سنجل بوينت. فالسباتيال ريزوليوشن بتعتمد على الويدث اوف ذا ديتكتور. اما التمبرال ريزوليوشن بتعتمد على الجانتري روتيشن. في الهاير اند ماشين الجانتري روتيشن دي ممكن تبقى 0.33 سكندز، وفي نيور ماشين ممكن توصل ل 0.27 سكندز. كمان ممكن يتحسن التمبرال ريزوليوشن زي ما دكتور محمد قال بالديوال سورس. الديوال سورس 2 سيبريت سي ارم ب 2 سيبريت ديتكتور بيتحركوا at the same time فبيسكان الهارت at the same time. فده temporal resolution. temporal resolution يساعد في الهاير هارت ريت. السباتيال ريزوليوشن يقدر يوري الكواليتي اوف ذا ايمج. والفيلوسفي بيهايند ال 320 ماشين مش علشان سباتيال ريزوليوشن، هو معمول علشان تو ديكريز الراديشن دوز. بما انه بيستخدم سنجل شوت يفريز الهارت ان سنجل كاردياك سايكل فهيقلل الدوز اوف ذا راديشن. فده الفروقات ما بين السباتيال والتمبرال.
Any other questions?
في سؤال بيسأل can we use cardiac CT to measure aortic stiffness؟
يعني we use cardiac CT for the aorta for very large amount of information we can get. You can first of all you diagnose aortic aneurysm, aortic dissection. Sensitivity for aortic dissection is almost 100%. At the same time, you can detect whether the area which is appropriate for intubation during surgery, and after surgery, the adherence of the aorta to the sternum, and for a redo operation and so on. But measuring the aortic stiffness by itself requires different computation. It depends on the amount of velocity of conducted waves from the aortic root to the bifurcation of the aorta. So CT is an imaging modality, is not a modality for testing the function of the aortic wall. So I don't think it's used for aortic stiffness, but it's used for aortic calcification and aortic anatomy.
اوكي تمام. الأسئلة خلصت.
أحمد شحاتة عاوز يقول comment at the end.
طبعا كانت محاضرة رائعة وأنا استفدت كتير من حضرتك يا دكتور محمد.
العفو.
كانت very illustrative وحاجة full of information. شكرا يا دكتور محمد.
شكرا يا حبيبي. خلاص we have to wait till next Friday. We will be talking about some aspects of coronary of cardiac MRI.
تمام. انتظار حضرتك.
شكرا يا دكتور.
تصبحوا على خير.
حضرتك من أهل.